I'm delighted to welcome back Christina Farr. Christina Farr is not only the top journalist in digital health, but she's also one of the 8 women making moves in tech. Welcome back, Christina.
I'm making faces because I'm like weird about compliments. So we've got a great group today. It's a smaller group than earlier, and we're going to be talking about aging in place, which I know is a topic that many of you are very passionate about and very involved with. So I was thinking we could just kick things off with just you guys giving us a 10-second or less introduction. Like, who are you? What do you do? Like, why do you get up in the morning?
All of that in 10 seconds? My name is Owen Tripp. I'm the co-founder, chief executive officer of Grand Rounds. We help people who deal with really complex cases get better care. We think the American healthcare system is terrific. We just don't use it properly. I get out of bed for that reason and for my kids and for the mission that we're charged against.
Stephanie Tilenius, co-founder and CEO of Vida Health, and we prevent, manage, and reverse chronic conditions, which represent about 86% of the cost of healthcare in this country. And I have 2 kids and get up every morning as well because I know I'm doing something to make our country better.
So if this were maybe 5 or 10 years ago and we were sitting on the stage, you would both be at technology companies and not working in healthcare.
Same technology company.
Yeah,
I think
actually,
if
at
we
one
go
point we
that
were
far.
both at eBay.
Oh, wow, you overlapped.
Yeah.
Was it Google?
eBay.
eBay.
Okay. And now we're talking about aging in place. So how did that happen? Like, how did you go from working in Silicon Valley and now being on stage, caring about this healthcare issue and forming healthcare companies?
Well, so I was at eBay and Google and have built platforms and products from the ground up, and I really think this is the next 10 to 20 years are going to be transformational for healthcare. I mean, I really believe my kids won't recognize the healthcare system that we all use today. I'm hoping that's the case. Yeah. And I thought, well, I can use my expertise in technology and platform and consumer to actually help in healthcare. And then I did have the benefit of my father had chronic conditions, and I watched very specifically what was wrong with the system and figured out a solution to fix it. So,
what about you?
I think that we speak for a generation of people who were able to be successful in other adventures before this. I was at eBay, PayPal, and then started a company called Reputation.com before this. And I think most of us are ready to do something that actually feels like it matters, really matters. Not the company that will sell in 2 years and the name of which you will forget 5 years after that, but the thing that maybe you could tell your grandkids about if you did it really, really well. Mm-hmm. And I think there are a lot of people. Stephanie and I are 2 of those people, but there are a bunch of those people in Silicon Valley.
Yeah.
So Stephanie, you mentioned your father having chronic conditions. What were a few of the things that you noticed when you were caring for your father, and I'm presuming you were doing that remotely from a distance?
Yes, I was at Google. He had CHF, COPD, diabetes. It was fun. So one of the things that was very clear is he didn't have a continuous advocate or a continuous care model at home. And so he would see a doctor, but the doctor visits were intermittent, and then all the things that he actually needed to do were pretty complex, and he didn't know what to do in between the doctor visits and how to continuously manage his condition, change his lifestyle, change his behavior, understand the connections between the comorbidities between the conditions. And the other thing is that these doctor visits are pretty expensive. They're 8 minutes, and doctors want to practice at the top 1% of their license. They want to fix things and they want to provide fantastic advice. But they don't want to work day in and day out with an individual to actually change their behavior or manage their lifestyle. Nurses, coaches, empathetic healthcare individuals who've been in these situations for 20 years who have experience with these kind of patients are much better at doing that. And the doctors actually want them to do that. And so we thought there was a way to, essentially offer a product where you could do text, audio, and video connection with these folks who can help you actually, either we reverse chronic conditions in many folks or manage more effectively.
So this term aging in place, what does it mean to you? Does it mean, being able to be at home most of the time? Does it mean, flying around the country and seeing specialists, but at least being based at home? What's the kind of definition for you? I'm assuming it's quite changeable.
Yeah, I don't love the label aging in place. I kind of wish it were aging the way you want to age, because you may want to be at home and you may not want to be at home, and that's really going to be a personal preference for a lot of different people. But I think what's universally true is you don't want to hit a wall one day and realize that you don't get to live the way that you have lived the rest of your life. And so I think that means that the intervention shouldn't require going to the hospital. The intervention shouldn't be as costly. The intervention shouldn't be as toxic. Those are the sorts of things that I think we need to be talking about. And I made a commitment to my team, and I've asked everybody at our company to try to think about this as well, to saying right earlier in your life what you actually want later. When you have a really good mind to do those sorts of things, state your preferences just to your future self. By the way, I think that's an interesting commercial opportunity if there are any entrepreneurs in the audience to go out and tackle that question. Freeze fire.
I guess similar to Owen, I think people should age the way they want to and where they want to. And just like, so we were both in e-commerce, and I'm on a retail board, and I see retail disappearing before our eyes, and I really think the same thing is going to happen in healthcare. Like, going to the ER is not a fun experience. Going to the hospital, you don't really want to be in the hospital when you feel sick. You'd prefer to be at home with your loved ones. And the great thing about today's age with mobile devices and Internet of Things and all these wearables, you can track your blood pressure, your blood sugar, your weight, all this continuously from devices, and alerts can be sent to your providers, and we can know exactly what's going on with you minute by minute in a much more effective way than we have actually in the past. And I think that affords people the opportunity to stay at home, be with their family, and it's also much cheaper than going into like a skilled nursing facility or these other, we've built all these brick and mortar locations which are really hard and expensive, and some people don't want it. Now, some people may want to be in them and others don't, and they don't want the flexibility of being at home.
And what are some of the cost savings associated with aging in place? And this is something we were talking about backstage. People can't afford to age the way they want to anymore.
I haven't looked recently at the data on SNFs, but I remember it's like orders of magnitude greater than staying at home. Like, I think if you stay at home and you get care, it's $40,000 to $50,000, whereas like a SNF is, orders of magnitude that. And then the scary stat that I recently heard was Fidelity, the average retiree of a Fidelity account they have $250,000 of savings, and they will spend $233,000 on healthcare. So, I think we as an economy and a government need to look at that and say, wait a minute, what can we do to help people not spend their last, when the last 10 years of their life on healthcare?
So what are, and you mentioned kind of wearables and Internet of Things and some of these terms that Silicon Valley loves, frankly, but what are some of the more concrete solutions that you see for people who do want to age where they want to, and maybe that's at home? Like, what kinds of tools, what kinds of devices, and who would connect to them?
Yeah, I think so. If you'll forgive me for challenging the question a little bit, I think sometimes we talk too much about the infrastructure and the gadgets and another thing to put around your wrist or do pulse oximetry or whatever you need. And let's talk a little bit about what are we going to do with that data and how do we take action on it. One of the struggles I have is that we're willing to now put cameras and sensors in our homes to alert the younger generation to what their parents are doing or not doing. But the question is, so then when that happens, what do you do with that, right? So can you alert your provider to it? Who's on the other end of that phone or that alert system? What information can they use? What actions can they take? At Grand Rounds, we're obsessed about the quality of physicians that are on the other end, and we can say physicians and also mean things like broad-based care teams. I think a lot of the innovation that you're going to see in the next 5 years isn't just going to be on the device side, Internet of Things side. It's going to be on the networks of people who can do care support, who can take action, who can interpret data, and help people avoid that extra trip to the emergency room.
I completely agree. I think we have a reputation in Silicon Valley for just talking about the device, but it's actually the whole service and the device and the person that's going to respond. And I think you're going to see a lot of service models like even ours that where like if you have a CHF patient at home and they've just had a heart attack or maybe they're a cardiac patient or a diabetic, what the doctors will often tell you is what happens after the 30 days that they are at home is not related to necessarily the surgery or what happened from the doctor's care. They may trip on their cat. They may, not be able to go to the grocery store because they're in pain. They may gain 2 pounds on that scale one morning. If they're a CHF patient, that may mean that they have, they're retaining water and they should see their doctor. So a lot of what we do is if you have a wireless scale, if you have a blood pressure cuff, if you have a glucometer, the data goes to the coach, and the coach immediately intervenes. So we work with Stanford and Duke with heart attack patients, and we recently had a heart attack patient who was 15 days out from surgery. I think it was a stent, and had pain down their arm, and our coach immediately got them to their provider, and they avoided having another heart attack. So I think a lot of these service models using the device data is really important. The devices alone aren't enough. Yeah.
And by the way, we have the most terrific device ever invented already in many of our pockets, including the most indigent among us, that has generally at this age a pretty good camera and a pretty good accelerometer on it, and you can do most of the work from there, right?
Yeah. Is this an iPhone ad?
I was going to talk about my Samsung Galaxy. No, I'm just kidding. It could be an iPhone ad. It could be an ad for any smartphone. Dr. Dorsey actually taught us this lesson at Grand Rounds, that a lot of the work that you could do with people who have movement disorders, Alzheimer's, et cetera, you can do with a reasonably high quality camera, and it's just as good, if not better, and more natural and less stressful when that person is in the home.
Yeah.
And that, by the way, those are growing diseases, big time.
Totally. And I feel like I kind of hate myself for having to ask this question, but you have to. This is healthcare. Who's going to pay?
Well, I think, we work with employers and insurance companies and then providers, and they pay because we're moving to a value-based care model where we can lower costs. So far, we see a B2B to C model. I think that's probably similar for you. We also have some consumers that will pay us directly, but our experience is that the healthcare system really wants to pay for solutions that are going to lower costs and lower total trend for these chronic conditions.
From my book, hard to know exactly who is going to pay. I can tell you from our experience, pretty determined, who's not going to pay, and I don't think the consumer is going to pay. I think that what will happen is if these solutions, unless they're really cheap, these solutions will be borne by, the lack of a solution that can be paid for by another part of the system will be borne by the family that has to take care of that person. And then, a lot of Silicon Valley people who are seeing these models now will say, well, we'll have a free care team provided by Pfizer to support the kind of ad revenue that's made available by having a regular interaction with that patient. And I think that may happen. In fact, I kind of picture that happening, but I hope it doesn't happen. And that's not picking on Pfizer specifically, in case anybody from Pfizer is in the audience. It's just saying generally that a lot of the ad-supported drug models have driven other innovation on the internet and under other sort of free services when there's really kind of a conflict of interest there.
Dystopian future stuff going on. Again, with this question of payment, one thing I've been wondering about is whether employers will ever pay for this, because when you've got you talk about the sandwich generation, Stephanie, when you have people who are caring for kids at home, they've got elderly parents who are aging, and they're flying out frequently to visit their parents. That's, in employer terms, that's like a productivity loss. Mm-hmm. And I wonder if they see kind of a future in which they might start to kind of offer these kinds of services, what you guys are working on to their employees.
Well, I think employers are offering both of our services, and employers, self-insured employers do cover healthcare. I mean, they are the largest. I mean, they're the largest provider of healthcare for their individuals, and there's the ACO pressure with the Cadillac tax, and so they are really trying to figure out what's right, and they really try to do right by their employees. I mean, they want to create the right culture and the sense of wellness, and they want to provide services so that their employees can be productive. And we see in our when we roll out with an employer, they often want us to cover not only the employees but the dependents, spouses. So I think that's a regular expectation. But I do think employers are very much focused on the employees that work for them. If we cover dependents, and the employees that work for them are the highest priority. So if it's a 84-year-old cancer patient, if they offer Grand Rounds, maybe the employee would use it. but they're not going to go cover that 84-year-old, right? So you're looking at the self-insured model is not really going to get at the Medicare as much. I think Medicare is a separate market.
Yeah, the Medicare Advantage plans, I think, offer some hope and promise on this idea. I'm sure there's some people here who are working on those, that you could actually have the opportunity for an independent entity outside of the government to create a plan that takes some of this risk.
Yeah.
I'm pretty hopeful about a lot of those. Some of it's already happening. And I think those, at least in our business, are going to be natural partners for things like specialty care, expert opinions, collaboration.
So one of the things another thing we talked about backstage is, if a parent chooses to retire to, say, Arizona or Florida, common places like that, I mean, how are they going to access the best specialists without having to fly across the country to, say, the University of Rochester, for instance? Can they see any of these top doctors at home?
Yeah, I mean, so look, Owen Tripp speaking here, but I think everything you have read about a physician shortage in this country is basically wrong, with the exception of primary care and some specialties in rural settings. And in those settings, almost often you can serve a lot of the necessary care through remote coordination, and then only redirect that patient to COE, a center of excellence, when you absolutely need to. But we have a real supply-demand imbalance, right? You have some of the finest academic medical centers right here in New York. And we have more academic medical centers than we have even for population. This is a big population, but way more doctors thinking and training and then want to stay in the tri-state area. We don't have really a single academic medical center, that I think rivals the ones here in places like the ones you mentioned. And some of the bigger systems, like the Mayos and Clevelands of the world, are getting ahead of this idea and trying to build up in those places. But generally, I think there's so many conditions that can be served remotely. And so my optimistic note on this point is that you're going to see telehealth surge, not just in the employer community like we serve, but in this group that we're talking about today.
Yeah, I think telehealth, I think we were asked, what would we advise the next president to do? And I think we all had, reasonably policy-oriented answers, and one of them is just interoperability, and telehealth is so obvious, right? I mean, everyone should be able to access their data, and everyone should be able to use telehealth. Why shouldn't telehealth be available in every state, and why shouldn't every licensed physician be able to work across all the states? It just makes perfect sense, and there is no historical reason other than lobbyists that this should not be.
I actually learned this the other day. It goes back to this, and I'm not making this up, it goes back to the Second Constitutional Convention of the United States,
okay.
That there was an establishment around what credentialing meant, and that included things at the times like blacksmiths, but also included doctors. And that's why we have the state system we've had today. And then subsequently it's been protected by interests that I don't think are aligned necessarily with great outcomes.
And one last question for you before we ask questions from the audience. So we tend to focus a lot on doctors when we have these conversations, but what about kind of other health practitioners and providers, nurses and so on, who, you mentioned earlier, tend to be the one that spends more time with the patient beyond that 8-minute visit? How can we really utilize their expertise in this kind of whole aging in place conversation?
I think it's a big opportunity. There's 3.5 million healthcare workers in this country. It's the fastest growing labor market. And even when you're in a hospital, the nurses do most of the work, right? And they have this deep connection with the patient. So nurses, coaches, are certainly in our system for chronic care, we're seeing do the majority of the work. And it's a good balance between the doctor and the nurses. And then we're also seeing some level of automation occur as well, although we don't believe that, there's extreme views about we will eliminate all healthcare human beings and we'll just have everything robotic and automated. We don't.
Some people do that.
we don't believe in that model. We actually think you need a human touch. But it's really amazing what nurses actually. They're sort of the unappreciated superpower, if you will, in the healthcare system.
And last question. In a word, and I know we did this earlier, but I love it. In a word, biggest challenge for aging in place kind of in the next 50 years? Or you can go with a phrase. I'm okay with that.
Entrenched.
Stuff. We're going to entrench the aging people.
I was going to say, I would say inertia and entrenched beliefs.
Oh, that's great. Love it.
Yeah.
compassion. I don't think we talk about this stuff particularly compassionately. And when you talk to aging people, like what they're asking for is oftentimes out of line with what we really super smart people are creating for them.
So they don't want robots in their home?
I don't think they want. They don't want. Turns out that tea kettle that like tells your kids if you haven't made coffee that morning, they hate that because they want to believe that they still have privacy and dignity over their own life.
Wonderful. So on that note, does anybody have any questions?
Hi, just a business model question. Clearly the consumers weren't your entry point, so that kind of leaves providers, payers, and employers. And it sounds like employers may have been a good entry point for you, but how would you rank them for your type of services?
Well, we work with employers, payers, and providers, and they're all, as long as they are at risk, they're all interesting partners, right? Because they have an incentive to move to value-based care and to lower cost.
We cover millions of lives in the United States and do consults in 100 different countries. It's almost all employer-led. So,
as you think about your respective businesses and kind of what you're trying to do right now, kind of given the relationship you're building with employers, what legitimacy does that give you to build out features and functionality going out in the future? What's the roadmap look like?
I'll let you go first.
Well, Jason, I'm not sure actually what autonomy or authority it really gives us on this question, although it does prove the model of cost savings. So in the Grand Rounds model, it turns out that when you consult with one of the world's finest experts on your condition, it turns out that not only are you getting better care, but you're actually avoiding the cost of bad care or interventions that are inappropriate. And so that we've now scaled that model out. We've been doing this a little bit longer than Stephanie's team has been doing it, so we just have a little more data, likely. And one of the things we figured out is that saves across our book of business. I think that will be applicable and interesting to the payers in the world and the Medicare Advantage plans and so on and so forth.
I mean, yeah, similarly, we pride ourselves on outcomes, and we focus on actually driving the cost trend down. And so the more we prove that, the more we can work with employers and payers, and we can do more. So they'll come to us with problems that they have and ask us to help them in various ways. So, I think we're both at the very 0.1% of the beginning of innovation in healthcare. And we both are building technology platforms that have a lot of extendability. So, we're just getting started.
Great, thanks.
We've got time for one more. Otherwise, you're stuck with me. No? Okay, I'm going to ask a question about patients because you mentioned compassion, and I think, we don't often talk about the actual human beings in these conversations. So, can you just give me an idea of what types of patients you've been working with? Do they tend to have smartphones? Is that as big a problem as we've been told, this whole smartphone divide? What have you found have been sort of the challenges that you didn't expect to have, but then you talked to patients and found things out? What are some of the learnings that you've had?
Let's see. Well, we have patients aged 13 to 84. So we've dealt with across the country, and we have some international as well, but majority are in the U.S. And I'm humbled every day by some of the cases I read and just watching. Actually, I'm most humbled by what our coaches do because, when we first started screening and hiring coaches, we looked for clinical expertise and empathy. And we'd still do both today, but I have really learned to appreciate empathy, and that gets back to your compassion comment. I'm just amazed at what the connection between the coach and the client and the consumer, what they're able to actually drive change. And so I think, in terms of smartphone, I'm amazed. Smartphone coverage is pretty wide in the U.S., even lower income, even if they are, living paycheck to paycheck. Or rent to rent. I mean, they tend to have smartphones. And some even older patients, we thought we wouldn't be able to really manage 70-year-olds or 80-year-olds. And they use Facebook, and their grandkids in some cases have shown them how to use these devices. And they love text messaging, and because we're a heavy text platform, they are pretty comfortable. Now, that doesn't mean that everyone has a smartphone. It's still growing, but it's not as much of a barrier as I think we originally thought.
Yeah, I think what I'd say is two things. One is that most people don't want to engage in healthcare until they absolutely have to, when they're dealing with one of the conditions like she mentioned or some of the stuff that they come to us for. And then they're really in it. And they are committed, and they will do everything they can, and they will do things that are beyond even their financial means to make stuff happen for themselves and for their families. And the other observation I have is that the healthcare is not a journey for most people that they want to do alone. And so you see people coming together. And if you are alone, your odds are significantly worse than if you're working it in a team. And so we create structures that bring team. I think the same way they do. And this is the work that a bunch of our folks have been committed to, including Dr. Marchek, who's sitting over there. She's one of our staff physicians. And it's just how do we surround these people and make sure that we're not only delivering amazing clinical expertise, but just saying we're there for them regularly.
Any more questions? I think we've got time for one more. Has anyone got one? Yes.
So how technology is great and it's wonderful, but in the end, medicine is about relationships. How do you develop those relationships and overcome some of the challenges that technology can have?
Well, we have longitude. Go ahead. Do you want me to? The question was how
Should we repeat the question? Does anyone not hear it? How medicine is about relationships fundamentally and not necessarily technology. So how do you overcome the barriers that technology poses to really facilitate those human relationships between doctor and patient and so on?
Yeah, so the human relationship between the coach and the consumer is really important. And, they text, they audio, and they video. And they, in some cases we've worked with provider groups, and the provider will come to us and say, how did you find out all this information about the patient? I've been working with them for 5 years, and your coach found out more information than I have. And so, we haven't seen a barrier. I mean, I'm sure there are people who won't use our product because it's technology centric, but, right now we're growing fast and we haven't seen an issue. If anything, there's a certain amount of confidentiality that they put in the coach what we've noticed is that people want to be their best self with the doctor, but they're much more willing to share with a coach or a nurse. And so it's really been productive. And we share that learning, with their approval with the doctor.
Technology for us is about doing things repeatably, scalably, and at incredibly high quality. It's not about the end service that we deliver. So what the technology is about is how do we take the idea of the chairman of surgery at Mass General Hospital and allow him to consult with every pancreatic cancer patient in the country? That actually 5 years ago was not an achievable idea. It's actually closer to achievable now. But that's not about the relationship with the patient. It's about how do we make that person and that team more proficient and excellent.
One more?
I'm Dutch. I was in the panel 2 panels ago. I'm impressed with what's happening in the United States. I'm actually curious, with all these companies that we heard in the last 2 panels, is there any overlap in your offerings? Is there any regulation? Should there be any regulation? Is the winner going to take it all? How are clients going to decide what is the best option? How are hospitals are going to decide? Can you give us some guidance on how the Americans see this?
First of all, we don't need more regulation. We already have too much regulation. I don't think our products are very different. They don't overlap. I don't see a winner-take-all in a long time because we're all just so new and getting started and changing healthcare. That's at least my view.
Yeah, and I think we do consults in, as I said, over 100 countries, or have done consults in over 100 countries. And I'm gonna profile you for a second and guess you're from the EU, and say that is that. What's that?
Is that height-wise?
No, I was just sure. So the
or the wooden bow tie, maybe.
so the interesting thing is that, like, when we were at eBay and Google, or she was at Google and PayPal, like, we were terrified of Europe's response to a lot of the work we wanted to do, and I think rightly so. Interestingly, in healthcare, you see more interoperability in Europe. Mm-hmm. You see actually a much more modern approach to medical records and medical record ownership. You see, the whole idea of value-based care and risk model has been thought of by all those governments, really, every government outside of the United States, for a much longer time. So we, at least, have actually had an easier time making the case in Europe.
Don't get me started on the NHS, though. Really.
That's true. That's true.
All right. Well, thank you so much for being here today. We had such a great discussion.
Thank you.
I'm sure if you have any more questions, can ask afterwards. Thank you.
Thank you very much for the panel, for raising some thoughtful points and good ideas to take over. And what we start seeing is that traditionally hospitals and pharmaceutical companies were focusing on product development, developing new drugs and so on, or developing some processes, cabbage, stenting, interventional radiology, and so forth. Now we're looking also at innovation on the clinical process side, how we deliver care, how we're using primarily, as you saw, mobile technology, video technology, in better, faster, and more comfortable ways to deliver care. And we're going to see a lot more of it in the next few minutes in the panel as we get organized. The next panel will be chaired by Jennifer Hajj. Jennifer is a senior consultant for the Sachs policy group here in New York City. Jennifer has historically dealt with the New York State Medicaid redesign team, the MRT initiative, which looks at delivery system reform incentive payments. How do we redo it and this structure? It's called the DSRIP program. She's also very active in advising and mentoring several healthcare technology startup companies. She put a nice panel together that we titled The Changing Insurance Landscape, because by the end of the day, somebody has to pay for everything. So let's give a big hand for Jennifer, for the great panelists coming on stage. Thank you very much.
Great, good afternoon. We're joined today by Karen Ignagni, the President and CEO of EmblemHealth, one of the nation's largest not-for-profit health plans, and Dr. Bruce Leff, a practicing geriatrician, researcher, and professor at the Johns Hopkins University School of Medicine. As you know, there are a series of complex challenges and opportunities facing the insurance industry today, and that's what we're here to discuss. So let's dive right in. Karen, turning to you first. In your opinion, how is this shift towards value-based payments influencing insurance design and products for the aging population?
Thank you. It's a great question, and it's a privilege to be on the program, and nice to be sharing the stage with you, Bruce. I think that the simplest way to think about value-based payment is to think about the payer and the provider finally being on the same side, because we're no longer negotiating payment by body part. So the incentives are totally turned upside down in a positive way, I think, because it makes both sides think holistically and be united in how the effort of improving quality, reducing costs, but also dealing with the whole issue of patient experience, which I know Bruce is going to talk about, and the previous panel did such a great job talking about. But that's the game in healthcare now, to make sure not only are you hitting the mark in quality, but you're hitting the mark on cost and performance and patient experience. And we'll talk more about that, I'm sure.
For sure. Thanks, Karen. Bruce, turning to you. How are providers positioning themselves to take on risk in this new value-based world? And do you think there are specific strategies related to the aging population?
Yeah, I think it's a great question, and I think there are a few ways to think about that. So, you know, the major provider, the insurer for older adults is Medicare. About 30% of that market is in Medicare Advantage, as you were discussing. About 70% of that is still in a fee-for-service framework. Earlier this morning, and I'm terribly anomic, I can't remember anyone's name, but the lovely woman from ONC, I don't know if she's still here, but talked about MACRA and mentioned that MACRA, the Medicare and CHIP Reauthorization Act, the thing that closed the sustainable growth rate, what Congress got for their 180 or $200 billion for that was a focus on quality. And that really does change everything, even if most providers don't quite yet understand that, because they are going to be measured and their reimbursement is going to be tied to that, and it is absolutely, completely a zero-sum game. So there will be winners and there will be losers. And I think the big challenge for the Medicare population and for people who take care of really sick people, and I think there's been less emphasis on that over the course of the day. A lot of the platforms and the technology, I think much of that is geared towards people who are less sick. But for people who have multiple chronic conditions and functional impairment and challenging social conditions, like the folks at Jack Resnick, who's sitting in front of me, takes care of here in New York, the quality metrics actually do not exist to serve that patient population. We're still in a very disease-focused quality metric world. We need to actually invent good quality metrics for that population so that we can judge quality, pay for quality, and engage in value-based payment. And then Medicare has a challenge in terms of turning proven models of care actually into payment systems. So I don't know if any of you have heard of the Independence at Home demonstration, which is a demo being run out of the Innovation Center at CMMI. It is targeted at the highest cost folks, the people who are definitely in that top 5%. Again, multiple chronic conditions, functional impairment, challenging social conditions, often homebound, people who cost the system $30,000, $40,000, $50,000, $60,000 a year. And we know from a CMS demo that if you have doctors going out to them in their home, providing longitudinal care, you can save about $3,000 per beneficiary per year. That's real money. Like, that's real money. So, but the ability to turn that into an actual Medicare payment, we haven't seen that yet, and that will take a bit longer. So I'll stop there for now.
Great. Thanks, Bruce. I'd like to dig further into the point around the realignment of payers and providers. What do partnerships look like now and in the future?
I think one of the issues is one of nomenclature. Value-based payments, is a broad category, and it means a range of things to a range of people. I don't think you can truly have value-based payments if it's upside only. I think we're kidding ourselves. So what we've tried to do is really focus on this realignment of incentives, both upside as well as downside, because then you do create the incentives that you're talking about, not only realigning the payment for the sake of doing it, but for the sake of really moving the needle and creating strong incentives to perform specific issues with respect to quality markers, which you negotiate across the table, economic markers, which you negotiate, and increasingly patient satisfaction, which you negotiate. So that's a very, very different. And if providers, clinicians, hospitals then begin to take risk, so they're responsible if they don't hit certain markers, then you've really changed the game. So much of what we have in the delivery system today is still upside down only. And it's not the type of strategy that I think is going to not only push the envelope, but it's not the type of strategy that's really going to create that enduring change. But it is easy to articulate what you ought to do, and many of you entrepreneurs, investors, and you know this well, but actually doing it, which we're the market leader here in this community in value-based payments, and I'm proud to say we have worked with virtually now a strong subset of the best performing hospitals that all of you would know, even if you're not from this area. And we're doing some very, very interesting things, moving the mark in terms of creating these both upside as well as downside risk incentives. But there's no one size fits all. That's the other thing to talk about, because how you're able to actually accept risk as a clinician, a group of physicians, individual clinician, or a facility, a hospital, really depends on what stage you're in terms of your infrastructure and your ability to develop. So what many of you know in terms of tech proficiency, support, and so on and so forth, that's going to be very important and really importantly repurposed for the purpose of helping clinicians and hospitals and others to actually manage risk, figure out how to actually perform in that very new environment. So I think this is a point in time where we really are at that fork in the road, where a number of things come together in a very, very intriguing way to create some very significant new models, I guess is the best way to talk about it.
Great. Thanks, Karen. Bruce.
So I agree with everything Karen said. I'll just take a slightly, an additive tack, I hope. And as a provider, I think that there should be opportunities for partnerships between insurers and providers around the data to truly affect care, right? So the insurers are dealing with mostly claims-based data. And you can learn a lot from all sorts of claims. But it's limited. Providers have access to the electronic health record, and there's a lot of good stuff in there if you can find it, right? That's not always the easiest thing to do. I think for a lot of the highest risk patients, there are still don't exist the kinds of structured data elements that actually could inform care. So for instance, functional status, the ability to walk, take a bath, eat a meal, manage your medicines, those data are really often not even in electronic health records. If you are functionally impaired, by any stretch, your healthcare costs are usually double or triple those if you do not have functional impairment. And yet those data are nowhere to be seen. The ability to leverage natural language processing, link to claims, and then have insurers tell us as providers useful, actionable, dispositive information to identify someone at risk for some outcome so that we can actually freaking do something about it, that would be lovely. That would really be a nice thing. We've actually been working on a project with a health system in New England to try and add, link claims and EHR and natural language processing to identify some of those geriatric risks. And then if we can link that information to actually clinical workflow, that would be manna falling from heaven, because workflow is God, really. I mean, when you're in the clinical trenches, workflow is God, and most things really do not help with workflow yet. And that's a really important piece, I think. So those kinds of partnerships can be leveraged.
Great point. And, we've talked a little bit about the payer perspective, a bit about the provider perspective, but there's one key missing part to the equation we haven't addressed yet, and that's the consumer. What is the role of the consumer in this changing landscape? And how do organizations like Emblem and Johns Hopkins promote consumer engagement and decision-making?
Sure, I'll start. So consumer engagement, patient engagement, I think is a really interesting issue. And I think a lot of the platforms and devices and technologies that have been discussed today are really at the very beginning of thinking about patient engagement. At some level, most things, I think, I won't be absolute, but I think most things today were really, at some level, they were engaging the totally engageable patient. So these are patients who, in a clinical trial, would be adherent to placebo, and they would have better clinical, so if you are adherent to placebo, you have great clinical outcomes, right? That is a marker of something good, which we don't quite understand. In fact, if you are adherent to a placebo that is even harmful, you have a better outcome. That has been shown. So the ability to really help engage, the ability to engage patients is not just to engage the engageable, because those guys are going to have good outcomes anyway. The key is to be able to take people who really aren't engageable, who are not that lowest hanging fruit, and move them to an engageable place. That's really hard. As far as I know, no one has really demonstrated that yet. That is, that's kind of the brass ring in my view. And I think hopefully that will come. I think the technology can be a tool, but it's by no means of any sort of solution. And it does take coaches, and licensed clinical social workers are utterly key in these kinds of situations in the clinical context, because they know how to counsel and create empathy and trust in ways that other providers don't, and nurses and coaches of all sorts. So engaging the unengageable, that's really a place to point towards.
I agree with you. I think you did a great job of outlining that. I'll pick up where you left off. I think there's a bit of a decision tree. So you want to make the system work for a patient, and that means that we have to personalize a system that hasn't been personalized. And people haven't, as you said, haven't really thought about it that way. So from the first moment as a household, what kind of coverage do you choose? Do you choose comprehensive coverage, or do you choose high deductible coverage because you don't want to allocate or place a claim on so much of your monthly resources? Are you willing to have a bit of risk economically? Does that work better for you because you have a lower monthly premium? Mm-hmm. Decision number one for a family. Decision number two, how do you think about networks? What's important to me as an individual? If I'm a family, what is the worst thing that could happen? Probably something to your children. What hospital, what clinicians would you want to see if something happened? Decision number two, and there's a cascade of decisions around that, but just to simplify it. Decision number three, how do you actually use the system when you need it? Can have all the fanciest bells and whistles, but if I can't get access to care at 2 a.m., a consult, information, if I can't figure out what to do, where to go, and have somebody support me in that point of time. So point in time, decision-making and decision support, that's the marker now. So that's why everyone is very focused on how do you incorporate things like telemedicine? How do you incorporate things like supporting people when they're at home, both from the standpoint of delivering drugs, from the standpoint of delivering rehab, from the standpoint of discharging individuals when they come out of the hospital, so have that continuum that works. That's what personalizing healthcare means, before we even get to the whole personalization of pharmaceutical products, et cetera, et cetera. But I think Bruce has done a very good job of talking about those are the elements. So if you're in the health plan community, you're suddenly really changing everything about your structure and design, because it's no longer a wholesale, but it's a retail model. So many of the supports that have been present in tech and the things that we know every day and all of us use, Amazon and so on, you have to incorporate those kinds of things into your offerings and deal with high quality institutions like Bruce's, so you have the caregivers who can actually walk the walk as you're putting together these resources. So it's an aggregation, it's a personalization, and it's making sure that you're really hitting the mark at that point of time when people need it.
Great. I want to pick up on a point both Bruce and Karen made regarding tools and technologies. What types of tools and technologies should insurers and providers be building or buying, and how are organizations prioritizing those objectives?
Oh, you go ahead.
For us, we're in the process of reinventing a number of things in the customer support area, because it has to be faster, it has to be transparent, and it has to be accurate, and it has to be comforting to individuals. So you put all those, you build a matrix, you put all those things together, and so it's a very different set of support systems that you're looking for. That's not to say that you don't want to have a very strong partnership with the facilities and the clinicians, and each and every one of us would want to go to. But in them, on their own, that's not going to work without all of those other supports. So you're really thinking about how do you use the intranet. You're thinking about call technology. You're thinking about telehealth. You're thinking about a range of tools and techniques and strategies that you can harvest and aggregate in support of the patient to make sure you are actually delivering on that promise of getting people to the right care at the right time in the right setting. That's the marker today. So it's all about here and now, on-demand healthcare, but making sure that it's not just rhetoric or empty promises. Now, when it comes to people who are challenged with respect to English not being their first language, you have to make sure that you're providing language supports that you can translate in that point in time for individuals who may have a question. You have to make sure that you're aware of and able to manage healthcare disparities. We live in a very complicated system now with people who are older, more chronically challenged, and I think Bruce did a great job of that, but also have disparities that, and not just healthcare disparities, I also should have talked about transportation disparities. It's easy for all of us in this room to get from point A to point B, but if you can't walk, as you said, if you can't afford to take a taxi and you can't walk, then imagine you are locked in. So we as a health plan have to think about how do you provide the services to those individuals so that they can access those services. That's a very different definition of a health plan than we would have probably articulated 10, 15 years ago, or maybe even 5 years ago.
Great.
So just to build on that, I agree with all of that. And I think I'm not an insurer. I am not a payer. I work for Mr. Hopkins, and he gets very anxious when I talk in public, I think. But, if you are an insurer, as a provider, when I think about insurers, I think insurers will need to make some choices. So if you're an insurer who's trying to make a book of business by reducing costs a little on a lot of people who don't cost a lot, you can't do that anymore. Basically, you can't do that. But I still think there are people out there who think they can. Or are you going to try and figure out ways to save lots of money on people who cost a lot? And how are you going to do that? And I think the key ingredient there is if you do not, as an insurer, if you do not start to acknowledge and address social determinants of health, I think you're going to be completely on the losing end of this bargain in a few years, because there are lots of people who are expensive in a given year. The key is to find, I think, as an insurer, people who are persistently high cost, right? Most people who have an expensive year in the next year regress towards the mean in cost. And if you're an insurer throwing a lot of stuff at someone who's going to come down anyway, you may pat yourself on the back, did a great job. Boy, that gizmo that we bought, that tech thing that we did just did great. But the key is to find people who are persistently high cost and bend their cost curve. And I think the people who will win on the payer side are the people who've figured out ways to get at that and acknowledge the fact that medical and social factors are part of the equation and broaden their mission. So, and I think this will start to come from CMS as well. I think you're going to start to see guidance and regulation that basically says health plans are going to have to get all their Medicaid patients signed up for food assistance. That's going to be the health plan's job. And at some level, that might be the right thing, because having food probably does influence health outcomes.
Actually, I'm glad you said that. One of the things that I think is really cool that Emblem does, we have a neighborhood care sites in some of the poorest neighborhoods in the boroughs here in New York. And there, we take all comers. It's a place where people can go for information and support, caring for the caregiver, because many individuals are at home caring for their elders or their relatives and have no support, so we do that. We also provide information on SNAP, the food stamp program, so people can take advantage of that. We provide information on other social programs so people can take advantage of that. We run exercise classes. We run meditation classes because often these individuals are very stressed, of course. Mm-hmm. Any one of us that had or presented with the disparities that we see in the community would be extremely stressed as well. And that is, we do that as part of our social responsibility and our contribution. No one has to pay anything, and it's open to the communities, the surrounding communities. And people, you build it, people will come. There's no question about it. And I think over time you'll see much more of that from the health plan community, because we're here, we're part of the healthcare community. We're knitting together this group of individual physicians, other clinicians and facilities to support our patients. And we found that this is a very important strategy to provide help, again, when people need it and where they need it.
Great. One last question before we open up the floor for Q&A. Karen, Bruce, you mentioned a range of new programs and supports. How do payers and providers engage the physicians in these new goals?
I promise not to be a physician, so you have to.
Yeah, I think that, so I'll put my real practicing hat on. I think that, how do you start to integrate the widgets? How do you start to create a way that all of this becomes relevant? And I think it's key for payers to understand what doctors do on a daily basis and how their lives are set up. our practice in Baltimore, I can't really say that we are a Mr. Hopkins will yell at me, I can't really say that we are a 21st century practice. I practice in what's called a regulated clinic. And I don't know if any of you are familiar with that term, but it's a way for academic medical centers to basically charge a facility fee to patients on top of their visit fee. The medical center has to adhere to all sorts of rules and regulations. And as a result, not politically correct, I think I'm practicing way below the level of my license because of it. So the ability to get me to practice at the highest level of my license would be lovely. And to, the notion that I want more data, I really don't. I'll tell you what I want, and I think Owen talked about it in the last panel. What I want the minimum amount of data at exactly the right moment to make exactly an important clinical decision that needs to be made then. No one's got that yet. I don't want blood pressures every minute. I really don't want to hear people's weight every day. I really don't even want to hear if their weight goes up 2 pounds, because that's something that my clinical team, my interdisciplinary team, should be taking care of. And I should be called in when what that person initiated did not work, and I can leverage my experience as what I would hope for is a pretty high expertise in managing complex, very complex patients with multiple chronic conditions and try and find the right solution. So I want exactly the right information at the right time. I want an EMR that gives me stuff that I actually need and where things aren't buried, and I want it to meld with a workflow.
Just one postscript. I think the other thing just to say, which supplements what you said, as also part of the Emblem family, we have one of the largest physician groups in the 5 borough areas. So we have 500 physicians, we have 150 primary care physicians. And one of the things that we have learned is that supplementing the work stream, the workflow of the primary care physicians with nurse practitioners, physician assistants, nurses, allows our physicians to practice to the top of the license. And the nursing staff love it because they can practice to the top of the license. So really creating this team approach is very, very important. The other thing that we have also found, not only with our own partnership, our own physician group, but working with other physicians, you're right, you don't want to be inundated with data as a physician. On the other hand, you might like to know that you just be reminded to check my feet if I have diabetes. Not that you're not going to, because you're a great physician, but you might be busy, you might think someone else is going to do it, just to have that little reminder, reminding you to it's time for me to get my pneumonia vaccine, things of that sort. That's the kind of thing in a disease management relationship using big data that health plans can do very productively with physicians. And physicians really respond well to it because now we're helping them. As you said, practice to the top of their license. We're not hounding them, but we're helping them manage the care and coordinate the care for those individuals who are very expensive users. It's the top 5% to 10%.
But that notice for the Pneumovax can't come by fax. That's
no, it's got to come.
No, I'm just saying, because this is what I get now. I have things coming in by fax. It's not integrated with my medical record. The patient does need a Pneumovax. A nurse should be able to enter that order for me to click and sign. Or not, that should just be a single click instead of
Well, you have to move to New York because we have Epic in our practice.
Oh, do
so
we do too.
We can link with
you.
We
do too. Epic is a 4-letter word.
I want to take this opportunity real quick to open it up to the floor and see if there are any questions.
Hi, Karen. A few years ago, I'm Tom Camber from Oates, and a few years ago I was at one of your neighborhood care centers up in Harlem, where my understanding was...
the kind of guy that took the Zumba class,
That's
right?
absolutely... That was there, and it's not working. The weight gain is happening, so I'm going to talk to you guys. But I was really impressed with this notion of bringing the healthcare to the local community and building a kind of really diverse set of tools on the ground, both to leverage technology and nurses, and I think social workers, if I remember. And it was a really neat model. So can you just comment a little bit on what you guys have learned from that and where it stands in terms of
We've learned that, and Bruce said this very well, the communities that we serve need help. And that's part of our responsibility. We're a not-for-profit plan. We feel very strongly about community responsibility. It is ours. We've embraced it. Again, we've not just talked the talk, but we walk the walk. We've just opened a new community health center, neighborhood care, out in Queens, so we're really excited about that. It's beautiful, and the neighborhoods have responded. Now I have a number of people who are writing me, which I'm happy to see, come to the Bronx, come to this neighborhood, that neighborhood. So we're really looking at this very seriously. A year from now, in a couple of months, we're going to be opening, for those of you who know, in this community in Brooklyn, on the eastern part of Brooklyn, it's been a healthcare desert. We're opening up a new center, and I've just seen the architecture for it. It's going to be beautiful in one of the most underserved areas of the country, actually. So that's the sort of thing that we're doing. We'll see us continue to expand, and we're doing that in partnership with our physician network because they feel as strongly as I do about this is, we've got something here, and we need to build on it, and we need to see how to most appropriately serve the community. But the point you made about social services, we think we have a role in letting people know about social services and support, translating a lot of insurance speak, things of that sort for people, and that we need to embrace it, and we have.
Thanks.
Sure. Any final questions from the audience?
Hi, David Guttag. Bruce, you were kind of critical of some of the existing quality metrics, particularly in how they're applied to complex patients.
Right.
How would you think about designing a quality metric that applied well both to the complex patients and kind of the meat of the population?
Yeah, that's a great question. There are a lot of people working on those sorts of issues now. So I'm working on that too over the last 3 years with funding from the Commonwealth Fund and the Retirement Research Fund and the California Healthcare Foundation, and most recently a fantastic partnership with West Health. We developed a national stakeholder group and have developed an approach and designed metrics for patients who are homebound. Right, because if a hemoglobin A1C is relevant for anyone, and I think that's arguable, but if it is relevant for anyone, then it's clearly not relevant for someone who's 90 years old and severely demented and bedbound, right? Because at that level, all that does is incent me as a physician to take a blood test that's not going to have any effect on outcome whatsoever. So the need for complex patients and having disease-agnostic measures, I think, is really critically important. I do think, going back to comments that Steve Landers made this morning, I think patient experience and caregiver experience is extremely important. I think that can apply across multiple, a range of population. You need to probably do a little bit of tweaking for some of the more complex people. For complex, and I think also for non-complex, the issue of access to care, a lot of which was spoken about today with a lot of the different platforms, is important. We find for patients who are homebound, the ability to talk to a physician at any time or a nurse practitioner at any time to get guidance on whether to sit tight or go to the emergency department just is like log order more important than just about anything, right? And we also have a hypothesis that the ability for providers, for docs and nurse practitioners and nurses to develop a sense of trust with a patient or even love. So Tom Lee, who's the head of Press Ganey, talks about this construct a lot, this notion of trust and love between patients and docs. That has a tremendous influence on outcome as well. But a lot of people now are trying to think, we have so many measures. Most of them are not terribly good in that achieving the measure is not necessarily tightly linked to a particular outcome. There are lots of things that we're measuring. They're nice to measure. We can measure it. There's an National Quality Forum endorsed measure. Let's use that. And a lot of work now, I think, is being done by a lot of the professional societies. And I think it really should be led by the professions to come up with metrics that make sense for the providers and for the patients. But that's going to be a long process. And it will be an ongoing process because measures should be iterated. And once a level of quality is achieved, you go on to climb the next peak and go up the next mountain.
Can I just say something really quickly? I think you did a great job in laying out some of the challenges. I would just say that there are too many measures. They're not coordinated. So if you're a physician, a hospital, your head is just spinning with the numbers of measures. And then lastly, it was, and this is a session in and of itself, those measures were designed to fit the white middle class population. Right. And nobody really wants to attack that in very direct ways and terms. But that's some of the challenge you have with individuals who have disparities, who are dual eligible, and we can go on and on, right. But that is something that I think is a very, very important challenge to get onto in the health policy community. But more needs to be done, and people just aren't talking about it that way, but they need to, because we want to get them right for the populations that are the most vulnerable.
And developing quality measures is a really expensive thing to do. To get a measure developed and through endorsement at NQF, it's about $1 million, I think.
And the government should invest in that.
Yeah.
That I can't think of anything more socially responsible and important about government investment to make sure that it's objective, scientific, and fair. Ultimately, bringing the right panel.
Karen, Bruce, I completely agree. I think I know.
So I'll just kind of make one last comment.
Okay,
so under MACRA, the use of registries can be used to get measures into value-based care, an alternate route to the National Quality Forum endorsement. One thing that these platforms that have been discussed today could be used for would be for patient-reported outcomes. So I'll leave it there, but it is an opportunity for the entrepreneurial folks in the room.
Great.
They'll have to invite us back to have more conversations.
There you go.
It's a great segue. Thank you so much, and really looking forward to next year's discussion.
Thank you very much, Jen. Before you go to our reception, we have a feedback form. Most of you raised your hand kindly to say you were interested in coming back to next year's d.health Summit. To make it most valuable and improve, please give us your feedback, and you can just hand it to Ryan and Stephen as you go out, or just return it to the registration desk.